All right, it is 12:30, so we will begin. Welcome. My name is Sarah Sims, and I'm the Assistant Director for Professional Development at the Brown School here at Washington University in St. Louis. Thank you for joining us today for our Open Classroom series. Open Classroom is the Brown School's virtual and free professional development series. As folks are getting settled in, I'd like to start with just some very brief housekeeping items. First is that we're using a Zoom webinar format, which just means that we can't see or hear you, but we do really want to hear your comments and your questions. There will be time for Q&A at the end. And so the way to do that is to just drop those things in the chat. So right now, please feel free to say hello, where you're zooming in from, why you were interested. But then throughout the presentation, please ask those questions, and then we'll kind of filter them and pass them to Dr. Newland at the end. And then the second piece is that we are recording the session today, and that recording will be made available on our website, which I'll share that in the chat and in a QR code at the end. It'll be shared tomorrow, so you can share it with your colleagues, rewatch, things like that. All right, so today's Open Classroom program is a part of our Black History Month series. And I really want to thank and acknowledge our entire Black History Month Planning Committee, especially our co-chairs, Amber Brown, who isn't here today, but Miss Cynthia Williams, who is here today. If you want to wave, Cynthia. She is our Assistant Dean for Community Partnerships here at the Brown School, and she's going to facilitate our Q&A at the end. So thanks to the whole committee for planning. So now it's my pleasure to introduce our speaker for today, Dr. Jason Newland. Dr. Newland is a professor of pediatrics here at Washington University in St. Louis and is the Schnook Family Endowed Chair in Pediatric Infectious Diseases at St. Louis Children's Hospital. His research has focused on the use of antimicrobials and the impact of an antimicrobial stewardship program at children's hospitals. Additionally, he led COVID-19 research efforts evaluating the rate of transmission in schools, the impact of routine school-based SARS-CoV-2 testing in North County, St. Louis, and effectiveness and safety of COVID-19 vaccines in children, which actually he did an excellent Open Classroom for us last year on that topic. So while he's talking, I will dig up that link and drop it in the chat if you're interested in watching that. And we are very pleased to share that Dr. Newland is, we named him one of our 2024 Black History Month champions, which I will put a link to that in the chat. I'm going to put a lot of links in the chat while he's talking. But today he is here to present Syphilis, an infectious disease perpetuated by social inequalities. So please join me in welcoming Dr. Newland.
Thank you, Sarah. Thanks, everybody. I'll get my screen up. So I am, I'm honored, I'm humbled, and I'm grateful to be asked a second year to speak for Black History Month at the Brown School at Washington University is a tremendous honor. To be asked by a dear friend, colleague, confidant, role model, Cynthia Williams, means a ton. I'm appreciative to Sarah, to Amber, to everybody affiliated with the Black History Month programming. And I am appreciative of the opportunity to learn. And what I love about my job is that the ability to continue to learn in many, many facets. And this is one of them. I don't know what you thought when you looked at the title and you heard syphilis, what you did. Did it make you uncomfortable? Did you have an image of what that person with syphilis looks like? But I can tell you, as a person that's been telling others about putting this presentation together, you get a lot of different comments. A lot of times they come around humor, right? The defensive humor that occurs when we talk about sexual transmitted infections. And so I think there's one piece of this that talks about the stigmatization of sexually transmitted infections that likely leads to some of the problems we have in our current ability to treat. And then I'd say the second piece, especially regarding syphilis, is likely who you see when you hear the word syphilis. And that potentially is rooted in the histories associated with syphilis. And a lot of that has to do with being black or being brown. And in this world and in this the theme of art of activism, what I'm hoping for you all to think about and maybe to help us moving forward is the activism part. And there'll be art, and there's art in how you do the activism, but we need to be activists, not only what I'm going to say about for syphilis, but I'm also going to say for medical research. So the talk you're about to hear is one that's been a labor of somewhat love and some of learning, and has, I think, many more versions in the future. I'm going to take you through three stories, essentially. One is the basics of syphilis, because I am a pediatric infectious disease physician, and I need to tell you about syphilis and teach you what syphilis is. Syphilis is a bacteria, just like any other bacteria. There should be no stigmatization about it. There are tests, there are treatments, and there needs to be more tests and more treatments. That's part one. Part two, that will then go and talk about the history of the United States Public Health Service in conducting syphilis research. And I'm sure the number of you, and maybe all of you, know exactly where I'm going. And I don't want you to be saying Tuskegee study. No, I want you to be saying the United States Public Health Service's untreated black male syphilis study at Tuskegee, and I'll tell you why. And then lastly, we'll talk about congenital syphilis. And we'll talk about the increases in syphilis and congenital syphilis. You have a pediatrician, and that this is impacting everybody, including the most vulnerable in our kids. So here we go. So syphilis, what is syphilis? Well, in that right-hand corner, you see it. It's a bacteria. It's just like the staph bacteria or the strep bacteria. It just looks a little different in that it's a spirochete, meaning it. Look at that image. You can see kind of the spirals that's associated. Now, that's made it somewhat difficult to have good diagnostics, meaning can I put it on one of those petri dishes and grow it? No, it's hard. But we can do better. We can come up with better tests, and that's something that we won't get into. But what happens? Well, this bacteria, and I should say, is the first recognized sexually transmitted infections dating back to potentially the BC era. So thousands of years, people have been infected with this spirochete or bacteria called Treponema pallidum. And there's different origin stories that I will not go into, but I would argue there might be some racism associated with some of these origin stories. But what happens? Well, if you have syphilis and it's a sexually transmitted infection, and you have a break in your skin or in your mucosa, so think of mucosa maybe as your lip, the vaginal tract, the penis, these places can have syphilis and then can introduce that to a partner. You'll see clinical manifestations, so rashes and such, that are mainly due to your body's attacking of that bacteria or the inflammatory response. And we know you transmit syphilis, the bacteria, mainly when you're in what we call the early stages of syphilis. So yeah, there's stages, and I'm going to tell you about them. There's an incubation time, meaning when I get infected to when I start seeing symptoms, and that timing can be as short as 10 days to as long as 90 days or 3 months. And on average is about 3 weeks or 21 days. So there's the primary syphilis, and for those of you in the medical profession and know this, I hope this is just a remembrance or reteaching, and obviously there's many experts out there that can add to this later. But there's the chancre. It's a painless, non-tendered, ulcerated lesion as depicted in that picture you see in the upper right-hand corner. And often you'll see that, again, it's painless. But in women, especially in the intercourse, when you have intercourse and you get it from regular intercourse, you might not see the chancre, but you'll have what we call lymph nodes. Kind of in that inguinal fold, which is between basically your belly and your femur, you have that kind of fold where those link, and you might see some big nodes there. I think it's important to note that you don't have to receive a treatment and that chancre goes away, right? So you can have syphilis, not know it, not realize it, and it's gone. So think about access issues. Think about, I don't know if I want to go see the doctor. I don't know if there's something wrong. You can see how you might not get treated. So if you don't get treated, you move on to the next phase, or what we call secondary syphilis, and that typically occurs 4 to 10 weeks 4 to 10 weeks after the chancre appears, and then it disseminates to pretty much all the other organs. The pictures you see is how it can manifest in your skin or on your tongue. And so when we think, if someone says I have a palmar rash, so on my palms, syphilis often comes into our thinking or into what we call our differential diagnosis. You can have low-grade fever, your joints can hurt, your body can hurt, and many will say it's the great imitator, meaning it can affect all organ systems. Now, importantly, you should know you can get neurosyphilis, and so it impacts your nervous system. It can make you have what we call a foot drop or different difficulties with your eyes, and you'll see that. But what happens next is latent syphilis. So you can actually have this secondary syphilis and then get better without treatment. And about 50, and secondary syphilis will resolve without treatment within 2 to 6 weeks, and then you're in a latent period. And what I show you on this slide is early and late latent, and that's because it impacts how we treat you. And it also means when you might see transmission for congenital syphilis, which we'll talk about later. Now, you can go in this latent phase and not have anything for a while, and it could be years. It can be up to 30 years before you have your primary infection till you have what we call tertiary syphilis. And that can look as skin manifestation as gummas, as you see up in this figure. You can have a saddle nose, which you'll see is in this, likely is depicted in this 1440 painting. And there's other kind of paintings and pieces of artwork that demonstrates kind of this saddle nose. And you'll see a saddle nose back here suggesting that, those way back when had this sexually transmitted infection. But it can impact all organs, especially the heart. So your aorta, right, this big artery that takes blood to all of our organs, can get inflamed. It can have what we call an aneurysm or an outpouching within it that's not supposed to be there. It can impact that valve that we have. All of these things can lead to significant complications as well as death. Again, it can impact your central nervous system with kind of this paresis where you can't feel things, this tabes dorsalis, and it can impact your pupil to where if I shine a light on your pupil, it doesn't react, it just stays frozen. Now, when I was asked to talk again at Black History Month, it was clear to me syphilis is going to be the topic. One is what we'll go into, but two is because of the dramatic rise we're seeing in primary and secondary syphilis across our country and really across the world. So you can see this figure, and I don't have to explain much, but you can see the dramatic rise, and you'll see that on the y-axis it's a rate. It's a rate per 100,000 persons. And if we went back further to the early 2000s when we had our lowest rate. And just to read you, this is a slide from the CDC, and we're really blessed to have one of the national experts at Washington University, Dr. Hilary Reno, here, who's contributed to a lot of this work. But during 2018 to 2022, the total rate of syphilis increased 76.7%. The rate of primary and secondary syphilis increased 65.4%. If we just take 2022, we had about 207,000 total cases of syphilis. And I'd argue that there's probably a lot more that are appreciated or not diagnosed. Now, I'm talking on Black History Month, and I think many people, when they think of syphilis, probably their mental image might be of a Black individual, maybe not. I say it's probably different if you think about hepatitis C or HIV, though they all have a healthcare disparity as reflected in this slide, where those people of color, American Indians and Alaska Natives as depicted in the top, second is Black. These are the highest rates, right? The rates meaning among Black individuals, you have a rate over 40 per 100,000, which is much greater, 4 times greater than those of white individuals. Being a white privileged male, I have been looked upon differently and have had a lot more, one would say, opportunities and privileges to allow me to maybe not to be in some of the vulnerable positions. And I think this is what is called upon all of us, and then why I am so thankful and grateful for again being asked to speak on Black History Month, because I do see myself as someone that can be an ally. And again, I'm so appreciative of being a part of the Wall of Champions. And how can we continue to do that? Well, I think one is fighting the stigma of syphilis as though and other diseases. So I use this slide to now kind of switch gears, because I think I'd be remiss not to talk about the United States Public Health Service syphilis studies. And I say United States Health Service, this is really the precursor to the agency that is known as the Center for Disease Control and Prevention. And why do I do this is because I think we have to know and we have to learn. And we have to be, we have to do better. We have to do better in medical research. Now, I have two really key points about what I'm going to talk about. And that the first is to say that there are many, many atrocities in medical research before the syphilis studies, after the syphilis studies, and a notion that there is mistrust and distrust among our communities of color. And I'm going to say our communities, both our local community, our regional community, our national community, and our international community. It is not just based off one or two studies. I'm going to focus on those studies when it comes to syphilis. But you can go and find many other books that we all should be reading, including Medical Apartheid by Harriet A. Washington, The Immortal Life of Henrietta Lacks by Rebecca Skloot. We should be looking at the Nuremberg trials associated with Nazi Germany. There are so many more. That's 1.1. Point two is that if you are or want to be a person involved in research, we must know this history. And we have to continue to further know this history, understand this history, and not stop. I don't think we can spend enough time on this. And I know I haven't. And I am going to do more. And I am so thankful for this opportunity because I have continued to learn. And why is that important? Because as stated by Sidney J. Harris, history repeats itself, but in such cunning disguise that we never detect the resemblance until the damage is done. And you know you're meant to give a talk when you walk out of your office and step outside before coming in and you run into your local bioethicist who happens to be a great friend. And we started talking about so many more different studies and trials and about the Belmont Report, but this is how we all have to be experts in this. Or these atrocities will continue to happen, and they will be based oftentimes in biases, especially around racial biases, around those who are impoverished, those who have less. Now, the first study I'm going to talk about is maybe one you haven't heard about. It's actually one I learned about as Miss Cynthia and I were discussing the U.S. Public Health Service untreated syphilis study at Tuskegee, and about this notion about inoculating people with syphilis. I had never heard of this Guatemalan study. And this was less than a year ago. You can hear Cynthia and I talk about some of this on a podcast that we did together called Capturing COVID that I've done. It's my shameless plug. But that was important that we had this conversation. And for this talk, I knew it was important to hopefully have some of you learn about this. So this was a Guatemalan study. And it really was born out of the fact, if you look in that bottom right corner, that the worry was that with our military service, that there was a lot of those military personnel, the men, being stricken with venereal diseases, so sexually transmitted infections. And they wanted to learn how to prevent it better. So in addition to condoms, what else could we do? As a matter of fact, not surprisingly, one would say, in 1904 in Terre Haute, Indiana, they tried to inject volunteer prisoners with gonorrhea, but they couldn't get them infected. So they abandoned that, and they had been collaborating with somebody from Guatemala, and so they proposed a study that occurred from July 1946 to December 19 1948, funded by the National Institutes of Health and led by Dr. John Cutler, who would go on to participate in the U.S. Public Health Service untreated black male syphilis study at Tuskegee. And again, the goal was to improve prevention of sexually transmitted infections. So it wasn't just for syphilis, but it was also for gonorrhea and chancroid. And chancroid is caused by a bacteria called Haemophilus ducreyi. What they did, and it's not clear how many individuals as you jump into it, and this was really brought to light by this wonderful researcher, Susan Reverby, who's pictured here on the slide. And she found the archived data, and they basically did a bunch of testing in vulnerable people, 1,300 prisoners, orphan children in orphanages, psychiatric and leprosy patients. One of the things they had was legalized sex trade where they allowed sex workers to go into prisons. And so one of the thoughts was they would have these sex workers who had gonorrhea and syphilis go into the prisons without those prisoners and follow those without syphilis because they knew who those were. But that didn't work. So what did they do next? Well, they decided, let's inoculate some individuals with syphilis and see what happens next. Yes, this was the study where they inoculated individuals with syphilis. There's no reports of that with the untreated black male syphilis study at Tuskegee. This slide is one of the hardest slides for me of this whole presentation because of the atrocities associated. This comes from the Presidential Commission for the Study of Bioethical Issues, titled Ethically Impossible, published in 2011. I hope you're reading it, but I will read it to you. Berta was a female patient in the psychiatric hospital. Her age and the illness that brought her to the hospital are unknown. In February 1948, Berta was injected in her left arm with syphilis. A month later, she developed scabies, which is an itchy skin infection caused by a mite. Several weeks later, lead investigator Dr. John Cutler noted that she had also developed red bumps where he had injected her arm, lesions on her arms and legs, and her skin was beginning to waste away from her body. Berta was not injected for syphilis until 3 months after Berta was not treated for syphilis until 3 months after her injection. Soon after, on August 23rd, Dr. Cutler wrote that Berta appeared as if she was going to die, but he did not specify why. That same day, he put gonorrheal pus from another male subject into both of Berta's eyes, as well as in her urethra and rectum. He also reinfected her with syphilis. Several days later, Berta's eyes were filled with pus from gonorrhea, and she was bleeding from her urethra. On August 27th, Berta died. The image to the right is kind of like the injection. This would have been the chancre. This atrocity was not known. It was hidden in an archive. Thankful to Susan Revers, who alerted CDC and the director. And there was a formal apology by President Obama in 2010. Boy, I was embarrassed I didn't know that. There were 2 reports that came out of this on the study of bioethical issues, Ethically Impossible, STD Research in Guatemala from 1946 to 1948, Moral Science, Protecting Participants in Human Subject Research. Guatemala published a report, Consentir el Daño, Experimentos Médicos de Estados Unidos en Guatemala, which means to agree to the harm. Medical experiments by the U.S. in Guatemala. Crime against humanity, racism, and discrimination were explicitly and consciously present throughout, is what it was argued, and it's clear that was true. Mind you, the Nuremberg trials were ongoing at this time, where Nazi Germany used those who they thought were less than Jewish populations to do medical research. There was a lawsuit, Geidel versus Syphilis, Kathleen Syphilis, who was the former governor of the state of Kansas, as well as the Secretary of the Health and Human Services. The court ruled they were powerless to provide any redress to the plaintiffs. However, a day later, on January 10th, 2012, the Department of Health and Human Services announced funding of approximately $1.8 million to improve treatment and prevention of HIV and other sexually transmitted infections in Guatemala, and to further strengthen ethical training on human research protections. This is one of those stories that's not talked about. This is one of those stories I think that needs to be more present and should be remembered every year, especially among us who do research. The one we most know, and I tell you especially our community of Black friends and colleagues know, is what was originally titled the Tuskegee Study of Untreated Syphilis in the Negro Male. It is the longest non-therapeutic experiment on humans in medical history. It was publicly known. In the bottom left corner is a publication title that I found on the internet easily from Journal of American Medical Association, one of the leading medical publications in our field, in 1936. And there were 13 more publications that went from 1936 to with the last being in 1974. These were known studies. This was publicly available. And what I want you all to do from here on out is not to title this as the Tuskegee Study. On November 30th, 2022, the CDC held a remembrance about the United States Public Health Service untreated syphilis study in the Black male at Tuskegee, where Ms. Lily Tyson Head, who if I recall correctly, his father or grandfather was a participant in the study, and she said the following: when you place Tuskegee in front of the name, it gives Tuskegee the ownership. It leaves a scar on the town of Tuskegee and of Macon County, Alabama. Tuskegee was not, is not the owner of the study. It is the United States Public Health Service study of untreated syphilis in the Negro male at Tuskegee. And it should be noted that throughout the study for the 40 years, white male physicians controlled the study and directed blacks to carry out the study. The hierarchy of medicine and science of these times initiated and perpetuated this fateful study that provided no real important new information, despite what others might want you to believe with some historical publications. So I hope you don't call this the Tuskegee study. And I was fortunate because I worked with an amazing group of people, including Ms. Cynthia Williams, including one of our wonderful research coordinators, Christina Evans, who alerted our research team to this remembrance of the United States Public Health Service untreated Black male syphilis study at Tuskegee. And I was able to see this live. I watched Ms. Head tell this story, and I remember it like yesterday. Now, as I said, I worked on this, and I'm grateful that I worked on this presentation. And there are many resources that you can go to learn more about this study. One of the originals is the book by James Jones called Bad Blood that was published in 1981 and 1993. There's another NOVA presentation that you can find on YouTube that was produced in 1993 called Deadly Deception. I would encourage everyone to watch the United States government apology on May 16th, 1997. And then again, you can watch the 2.5-hour recognition, remembrance, and reflection that was conducted at the CDC a little over a year ago. What I'm hoping to do next is to really let's understand more about this study. What were the drivers and what was the beginning? Well, if you take back to history, at the turn of the century, the germ theory was becoming more and more acceptable. And it became more understood that a germ didn't see an individual by their race, right? Race is a social construct. That the amount of pigment in your skin, a bacteria, a virus, a parasite, a fungus, doesn't care, right? We know that. Now, the white population at the time would tell you they saw this as maybe a threat, and they need to understand this better so that they would not be getting sick from black individuals. Racial undertones or the racism that was prevalent. And then there was also, especially in the late 19th century on into the 20th century, about eugenics, that we improve the genetic quality of the human population, meaning there were those who were less and that we should do things so that they don't procreate, and that since they were less, there shouldn't be more of them. They weren't as intelligent. And that was our black colleagues and friends. That was those people. It was the Jewish population in Germany. So eugenics was popular. And there, as is stated in Bad Blood, virulent racism among researchers. African Americans were viewed as notoriously syphilis-soaked race, not as intelligent and not as willing to do the studies. Now, in the early 1930s, there was a project in poor black counties to diagnose and treat 10,000 people with syphilis. One of those counties was Macon County, Alabama. And at the time, there was approximately 27,000 residents, of which 82% were black. And a description of what this county was like was cruel, yes, cruel, C-R-U-E-L, rural poverty, with pelagious diet, which means malnourished, right? Where getting food could be difficult. And it was found that when they went to test in Macon County, Alabama, which is where Tuskegee is, 35% had syphilis. Now, they were only able to treat a handful. And it wasn't felt that they were going to be able to treat everyone. And while race was a predominant driver in the racism to do this, poverty was also. As a quote from Dr. H.L. Harris stated, "It is useless to attempt to cure syphilis in the rural Negro population in Macon County, Alabama, until and unless some ways is found to treat the large number of cases of tuberculosis, malnutrition, and pellagra, and also to give some fundamental training in living habits with the necessary attention provided to enable one to earn a living." Dr. Taliaferro Clark, who was the head of the venereal diseases branch of the United States Public Health Service at the time, as they weren't going to be able to treat everybody with their goal, said, wow, we shouldn't stop. Macon County is a natural laboratory, a ready-made situation. The rather low intelligence of the Negro population, hear the eugenics, hear the racism, depressed economic conditions, the poverty, the vulnerability, and the common promiscuous sex relations not only contribute to the spread of syphilis, but the prevailing indifference with regards to treatment, suggesting that our black colleagues and friends didn't even want to be treated for an infectious disease. Some might say we still have some of those views toward our colleagues and friends. So who are some of the members that participated in this research? Who were the research team members? There were many. The story is deep and has many layers. I'm going to try to tell part of it for understanding. The initial study was proposed to be a 6-month study. They partnered with Tuskegee Institute. And it was clear that Dr. Dibble from the Tuskegee Institute wanted to make sure that treatment were given to the participants. Some probably got it, but it's clear not many did. What Dr. Dibble thought was, while this will not bring in any additional compensation because we didn't pay Tuskegee, but Tuskegee had this medical institute. We could do labs. We could do autopsies. We could do all of these things. We needed Tuskegee. There was no payment to Tuskegee. But Dr. Clark, he said our own hospital and the Tuskegee Institute would get credit for this piece of research work. He also predicted that the results of this study, at least Dr. Clark predicted, will be sought after world over, and Dr. Dibble trusted Dr. Clark. Dr. Clark was able to get the Surgeon General, Dr. Cummings, to be in favor of this. Dr. Taliaferro Clark worked with many individuals to develop the study. His initial field officer was Dr. Raymond Vonderlehr. If you remember from the original slide, that was the initial person on the first publication. Vonderlehr was the person that made sure it went beyond 6 months. He's the one that said, hey, we're now seeing that the black individuals have syphilis that's just as bad as the white individuals. I didn't tell you this before, but there's many thought that black individuals didn't have bad syphilis. They thought there was a difference, so they needed to understand in their paper from Oslo, where it was all whites, but they were poor whites, by the way, that they did something maybe similar, but it was more retrospective, meaning they were already in the hospital, they had died, they did autopsies. Vonderlehr wanted to show, hey, we'll do this prospectively, we'll do this better. We'll take some people, not treat them, and see what happened. And as he saw that they weren't, that race, as he saw race didn't matter in the severity, as we know, he said, let's keep it going. Let's make sure we do it more and more. And they were smart. Dr. Dibble found this wonderful, wonderful black nurse, Eunice Rivers Laurie. She was a state public health nurse, and during the Depression was out of a job and came and worked at Tuskegee. And she knew she would make sure that the doctors, and she thought that they would make sure that these people were treated. And there was some thinking, and if you look at the stories, the participants were getting placebos. Nurse Rivers thought, hey, this is my family. She made sure they had exams. She cared for them. She made sure the public health service officers treated them like people. Because often, you can imagine, those participants didn't get treated like people. They got treated like less. She advocated for them. And she wrestled with the fact that there was those in the community who wanted to be a part of the study. And she felt bad that they couldn't. You know why? Because they actually could be seen by a doctor and some of their ailments would be treated. They get hot meals and other things. But she was a nurse, and she said, as a nurse, I didn't feel that was my responsibility. As a nurse being trained, we were taught that we were never diagnosed, we never prescribed, we followed doctors' instructions. Susan Reverby feels that she probably helped some men get out of the treatment. And there's actually a movie and a play called Miss Evers' Boys, which I'd suggest is racist in connotation. It almost puts it all on Nurse Rivers. It doesn't really talk about how this was driven by white physicians, driven by racist thoughts and biases. So who were the participants? Well, there were 623 poor black male sharecroppers in Macon County, Alabama, working for white individuals saying, these are our sharecroppers. These participants were promised things they'd never seen before. Free physical exams and treatments, free rides to clinics, hot meals, free treatments for ailments. And maybe one of the saddest things, because what Dr. Vanderlehr said is at the end of the study, autopsy, to get more participants or to make sure they stayed in the study, he gave them $50. He gave $50 to the families as burial stipends that paid to the survivors so they could have a proper burial. And finally, they were told they had bad blood. They weren't told they had syphilis. They didn't know what was going on. They just wanted to have something better for them and their families. The image to your right, the image that you see on this is the cerebral spinal exam. They had spinal taps done. To do the spinal taps, they were told it was a special free treatment. There is government documentation sent that they have saying that this was a treatment. It wasn't a treatment. They were looking for neurosyphilis. They wanted to know the complications. There was no treatment. There was no informed consent. There was no provided information or knowledge, especially as the government was pushing for syphilis treatments, all during this time. So we had treatments in 1932. They were toxic at times, but they treated individuals. There was the Venereal Disease Control Act that pushed for syphilis treatment before we had penicillin. Penicillin came about in the early 1940s and was a cure for syphilis. The participants were not told. There are stories where one of the participants tried to go to Birmingham, and lo and behold, one of the researchers showed up and says, "Wait, you're not supposed to be here to get treated." They told private docs not to treat them, though none of these individuals were going to private docs because they didn't have any money. They were poor sharecroppers. As a matter of fact, there was whistleblowers that would try to get this stopped in the late 1960s, and CDC met to discuss the study among all white males that looked like me. Supposedly one dissented, but they all said, let's keep it going. Until 1972. On July 25th, Gene Heller, an investigative reporter from the Associated Press, released this publication that I like to say is in the New York Times on July 26th. And she learned from it from a social worker and epidemiologist, Peter Buxton, who at the time was in San Francisco treating sexually transmitted infections and trying to get more people with syphilis treated, and heard of a doctor in Alabama being reprimanded for treating a rural Alabama for syphilis. The doctor reprimanding that clinician down in Alabama was Dr. Yes, the one a part of Guatemalan study. Dr. Buxton, Peter Buxton, put in files of official protests in 66, 68. He actually went in person to have a conversation and was again reprimanded by Dr. Cutler. And in 1972, he leaked this to Edith Lederer, who said, I'm not an investigative reporter, who sent it to Gene Heller. And what was the outcome to these men? There was 439 who had syphilis. They were enrolled. They had to be over 25 years of age, and they had to have 5 years. They were all men, all black men. They also enrolled another 184 controls. I found so many different numbers of how many was enrolled. I found 600, 623, 624. What I can say is that there was a lot. We know there was for sure 28 died directly of syphilis, another 100 from complications related to syphilis. That's 128. We know there's 40 wives infected, though I think there might be more. I think it's underappreciated. And what we'll talk about next is congenital syphilis, and there was 19 children born with congenital syphilis. As I said before, 13 manuscripts published. And after the outcry and the many investigations by Congress, the National Research Act of 1974 came about, which led to the Belmont Report. And all of you who have been a part of medical research have done your city training or some sort of ethical training, and you're tested on the Belmont Report. The question is can you remember respect for persons, beneficence, and justice? Do you know what those mean? And I'll be honest with you, I should know that. We should all know that by heart. We should know that respect for persons is the requirement to acknowledge autonomy and the requirement for those with diminished autonomy. That's making sure we have informed consent. Beneficence is defined as an act of charity, mercy, and kindness with a strong connotation of doing good to others, including moral obligation. In the Belmont Report, it is persons are treated in an ethical manner, not only by respecting their decisions, meaning if they say no, that means no, and protecting them from harm, but also by making efforts to secure their well-being. Our participants have to be of utmost importance. And finally, justice. A distributive justice, meaning the poor vulnerable didn't take all the brunt. And the goal of justice was the fair allocation of society's benefits, right? The benefits, meaning if there is something really, really good, everyone has access to that research, but also the burdens. We have to be better understanding respect for persons, beneficence, and justice as we develop and conduct our research. Some other unsung heroes: Dr. William Jenkins, an epidemiologist, attempted in 1967 while working at the CDC to send information to national newspapers through kind of an underground network that nobody paid attention to. He then, after the July 26th publication and the research in the National Research Act, ran the health benefits program that allowed for all the participants to be treated and cared for throughout their life. And then he led the important Syphilis Study Legacy Committee that led to the President Clinton to offer a public apology. I think we all should listen to the public apology. I watched it 1.5 times for sure. One of the people that spoke, as you see in this image, is Herman Shaw, who was the participant for all 40 years. I took snippets of his comments. You should go and listen. He said, "We were treated unfairly like guinea pigs. We were not pigs. We were not dancing boys." That's referring to the Miss Evers play and movie. "We were all hardworking men and not boys, and citizens of the United States." And then, in the ultimate show of grace, he said, "Never too late to work to restore faith and trust." Never too late to work to restore faith and trust. We should all be able to do that if he can. And Clinton then got up after Mr. Shaw spoke and said, "Your federal government orchestrated a study so clearly racist." And then he said, and which is also referred to as the most important part of his words, "What was done cannot be undone, but we can end the silence. We can stop turning our heads away. We can look at you in the eye and finally say on behalf of the American people, what the United States government did was shameful, and I am sorry." He also went on to say, which would happen next, was they would build a permanent memorial at Tuskegee and establish a center for bioethics. Human Health Service would look at how to best involve communities, all communities, in medical research that is positive, strengthen medical researchers in bioethics, and have postgraduate training for bioethicists. This was tremendously impactful, but I fear that we sometimes or oftentimes forget. So I'm going to turn my last few minutes before questions to congenital syphilis. I'm a pediatrician, we have a problem with congenital syphilis. We have a problem that I think is rooted in the history of looking at syphilis as the poor, vulnerable, Black, brown individuals, and we're not doing enough. I am lucky to work with Dr. Elizabeth Daniels, who is one of our amazing third-year Pediatric Infectious Disease Fellows who will be a faculty member in the coming year, and her mentor, Dr. Hilary Reno, who is an amazing, amazing individual who has been leading efforts to improve our recognition and treatment of sexually transmitted infections, and especially some new work. You should have them come speak to you. But you should know congenital syphilis is transmitted across the placenta, and the risk of transmission is early in those primary and secondary phases, and about 40% will be born without clinical symptoms. A baby that's born as a stillborn, meaning born dead after 20 weeks, could have syphilis. That is a complication of congenital syphilis if the mother is not treated. And there's many other consequences, including blindness, deafness, cognitive impairment, big spleens, big livers, all kinds of things, including rashes. And you might have heard about this recently with these publications: epidemic of congenital syphilis jumped tenfold, infants are born with syphilis in growing numbers, U.S. syphilis cases in newborns continue to increase. And it is true. It is true. This is out of the CDC, and all you need to do is look on the right side of this figure, or look at the figure. Blue is the congenital syphilis cases of these blue boxes, and then the black is the primary and secondary syphilis cases. It's rising. And again, I should say, these are Dr. Daniel's slides that she's so graciously allowed me to use, and she had done some amazing work looking at this and says, why are we struggling? And I agree with her. 100% of congenital syphilis are preventable. The real question is why? So she's looking at this. She looked at 134 mother-infant pairs to see in our local community among BJC and our BJC network, and found 74 cases of congenital syphilis. And what did she look at? She said, well, what's these syphilis pregnancy outcomes of those who had congenital syphilis? No timely prenatal care and no timely testing, no timely syphilis testing, no adequate treatment, late identification of it, clinical evidence despite treatment, and then evidence of relapse and reinfection. And the most common is lack of treatment. They might have tested positive. And you're saying, well, why? Why does that happen? Shouldn't they just want to be treated? Yeah, they want to be treated. I can tell you stories of some of them getting 6 or 7 treatments, but they got the wrong drug, or the timing was messed up because they didn't have transportation. When we look at the lack of treatment, again, a lot of it's inappropriate timing, or we gave the wrong drug. And the take-home points from this initial part is insufficient treatment, and then infection and reinfection late in pregnancy is a problem. Hence why we have to be testing our pregnant women for syphilis in the first trimester, the third trimester, and at time of birth. And not surprisingly, as you can imagine, if you look at the social vulnerability index, those with the highest number means the most vulnerable, that's where our congenital syphilis cases are concentrated. And we know, if you look at this map where you see Jennings and you see right along here along the river in the city, we know that's predominantly our Black individuals in our community. We know it's our Black friends and colleagues and their neighbors and others who are taking the brunt of this. And it's more than just about the demographics. It's about not having optimal prenatal care. So 46% of these congenital syphilis cases didn't have optimal prenatal care. And another 42% had a history of substance abuse of the congenital syphilis. And when you look at a big statistical analysis of this and you bring in all the factors, the key factors are not having any prenatal care and being housing unstable. But there's overlaps, right? If you look at substance abuse, that is limited prenatal care and no prenatal care. And if you look at lack of prenatal care, there's a large proportion that have a lack of insurance. It is so multifactorial, and it is so rooted in a lot of the inequities that we have, and they continue to be going forward. And so, not to belabor as I get to the last minute, I will say this has impacted us forever. Racism has driven it. Congenital syphilis is impacted by more than just what you look like, as we know. Race is a social construct. There are many other factors. We haven't done enough research. We don't have a good test. We only have one true demonstrated medicine called penicillin benzathine, which is on shortage. So you could actually go and not have the recommended therapy and not know. And I think what I want to say is that every year, I would say on July 26th, every year, or maybe that whole week, we should stop and recognize the atrocities and what they can lead to and what they will lead to and how much harm they will. And if we don't remember, they will keep happening as they have. And so I am not one to end without a couple of great quotes from John Lewis. So I think they matter in this. One is, ordinary people with extraordinary vision can redeem the soul of America by getting what I call good trouble. We all know he's well known for this. And lastly, this should guide us as well in what we do, and what we're trying to do is this. So I say to you, walk with the wind, brothers and sisters, and let the spirit of peace and the power of everlasting love be your guide. And with that, I will end, and I appreciate this opportunity. Look forward to questions and discussions.
Jason, my friend, this was very, very powerful. If you hear my voice is different, it's because I'm kind of choked up, but thank you for your activism today. And what I like to do is share with you, Sarah and I will share with you some of the comments that were in the chat. And one of them that struck me, and I understood what she means, she said, "This is too heavy. How can I unhear it?" Another one said, "Nurse Eunice Rivers Laurie was victimized as well." One of my other favorites, "Thank you, Open Classroom, for this invaluable information as this older adult, 73, navigates the intimate sex scene. It is essential that awareness is extended of latent syphilis." I'm going to turn it over to you, Sarah, for your a response for Jason.
Sure. So I'm not a science or medical background person. My background is actually in history. And the whole time you were talking, it just really struck me like how your presentation was also just a lot about history. And I know that, in recent years, there has been a call and a move for established practitioners as well as students in the medical field to receive more education and training in DEI, and maybe more in the the operational meaning of DEI, so that they can better interact with patients in a more equitable and inclusive way. But I also wonder if kind of what your presentation was doing was making a call for more history education for medical practitioners and students, and like to really understand our history on a deep level, like you calling on us to not refer to it as the Tuskegee study, but the US government study on XYZ. Like, yeah, I wonder your reflection on that, like that the power of an interdisciplinary education for medical or research professionals.
Yeah, well, thank you for those wonderful comments. Thank you for those who put those in the chat. And I'd like to say, I want to unhear this. I want to unread it. But I'm a part of it, right? People that look like me are a part of it. I got to reconcile with that, right? So I got to be a part of making it better. And Sarah, to your point, if we don't remember and understand the history, it is clear we'll keep doing it, right? It pains me to think that, as you said, DEI, and as we've tried to work on our wrongs to make the world better, we have places in our country, including maybe our own state of Missouri, where they're going to try to get us to quit saying DEI because they don't want us to talk about the history. They want to come and say, "Hey, we were okay. We were just trying to understand." That's a load of crap, right? And I think that when you say that, yes, we have to understand the history, and we have to be activists, which means, right? And I'm not one to say I want to be ever political, but I want to be active, and I want to be an activist. We have to vote, because we can't. Our community, our communities, and that's all of our communities, is dependent on every person can walk into a room and be a person and not something else because of the way they look, the way they act, or what they decide is their sexual orientation, or what they decide is what their gender is. That can't be the way it is. And that's what this is to me. And I think medical research has the ability to help that. But we have a lot, we have a lot to do.
Yeah, and I hear your passion, and so do lots of commenters, and I think like that just speaks to the power of that. Well, first seeking out that historical understanding, and then, you know, applying it to what you do today, and not just applying it to your job, but applying it to your own identity within your job. And I think, you know, one of the comments is your empathy, compassion, and strong passion as it relates to this topic is, you know, very unmatched and very visible. And I think that is what that interdisciplinary, right, education can do for folks in this area.
There is something about going where you're uncomfortable, right? There's something about having a dear friend like Cynthia Williams, who went to where she was uncomfortable to engage with me, and engage with me with very uncomfortable conversations as a white male professor at WashU, and engaged me to tell me how I was not being thoughtful and being racist somewhat in my thinking, to address the fact, and she did that to make me better so that I could understand, so I could be here today. That's where it comes, right? You got to do that. We rely too much on being comfortable. We rely too much on making it easy. We look at the IRB and says, how can I make it easy? I'm guilty of it. You can ask. Cindy Terrell's on this. She's one of my dear coordinators. It's been about the IRB her whole career. I have had to learn. And that's what we have to do. We can't think it as a rubber stamp. The IRB is not a rubber stamp. You might not like what they tell you, but you got to remember where it's rooted in. And we got to be better. It doesn't mean we can't make the IRB better too, but we got to work together, or we will have more atrocities, and we will impact people, and we won't impact the people the way we should. And that's what I care most about.
Well, thank you so much. And I love that you ended on like the power of relationship and the gift maybe that Cynthia gave you of calling you out and calling you in.
She does it all the time. That's why I'm here. I'll do anything for you. Cynthia Williams, you're the best.
Well, speaking of Cynthia and all that she does, I do want to make sure that everyone is invited to our next sorry, trying to do two things at once. Our next Black History Month, we have 2 more to go for this year. And they are here. Sorry about that. Took me a second. We have 2 more on February 22nd and February 27th. These ones are more on the topic of the arts as we traditionally speak about it, and activism. And you can use that QR code to get to the page to sign up for them. You can also use that QR code to get to the page where we have all of our recordings. So you can find a recording of today's presentation, and it should be posted sometime tomorrow morning as soon as I can get to it. So again, thank you so much, Dr. Newland, for your presentation and the research that you put into it for today. And thank you, Ms. Cynthia, and the entire Black History Month committee for inviting Jason and organizing this year's program. And we will see you all at the next open classroom.